Okay, so now we've got another virtual presentation. This one is from Chris Drews, the Health Service Manager in the Coonabarabran team. And she's talking about fall prevention from birth at Coonabarabran Health Service. And it looks at providing really intergenerational change to establish health literacy and engagement, and really with a primary health programs targeting healthy lifestyle choices and preventable measures for chronic disease. Chris, our health service manager at Coonabarabran, has a long career in health across a range of portfolios, and currently the health service manager, as I said. And she's really proud to manage and guide her team. There are a couple of other important people she'd just like me to mention, which Jennifer Staniforth is a child and family health nurse and midwife who actively engages with clients in promoting healthy lifestyles. And Narelle Andrews is an Aboriginal health professional and endorsed enrolled nurse. And Narelle works with the wider team to provide cultural support and inclusion for Aboriginal people. Welcome, Chris.
Chris, I'll do your presentation from here.
Thank you. Afternoon, everybody. I'd just like to do a bit of acknowledgement. I come to you today from Gamilaroi country, so I'd just like to acknowledge the traditional owners of the Gamilaroi Nation and elders past, present and emerging from within the Gamilaroi Nation, as well as where you are today on Wiradjuri land. So this is just a picture of Coonabarabran Hospital. Coonabarabran Hospital is about 60 years old in infrastructure. And it's approximately 2 hours northeast of Dubbo. So Ash initially contacted me and said, "You've had a 50% reduction in falls over the last 12 months. What did you do?" And I went, "Nothing special." And then when I actually reflected on it, what we did was discharge the patient. But it's how we got to that point of discharge that was the key focus. So we had at the end of 2022, we had a very complex patient admitted with a very early onset dementia that leads to blindness. So she was blind. She was under the age of 65. She was showing aggressive tendencies, and she'd been having recurrent falls. And because of the nature of her dementia, she would just be walking across the room and then would think that there was a chair behind her and sit down. So not all falls were falls. It was actually the patient trying to sit on a chair that didn't exist. So falls became an all-staff responsibility. It's a focal point at our safety huddle every day. We do that huddle every day at 9 a.m. and that's a full staff huddle. It's not just a nursing huddle. So our patient support service workers and cleaners and cooks, kitchen hands, they all attend, and they are all advised as to which bed numbers of the patients that have a high falls risk, a high behavioural or wandering risk, or high risk of pressure injury. Once a patient's admitted, we do a strategic bed selection so that we maximise patient visualisation. You'll see a photo further on. We're a long Nightingale shotgun style ward, and so visualisation of patients is really quite difficult. Across 2023, we had 2 supernumerary staff. So we had an AIN Certificate 3 trainee and an RN Aboriginal cadet, which provided 3.5 days a week on a morning shift where we had supernumerary staff that were able to do interventions with our high-risk patients and maximise supervision. We put in early referral to physiotherapy. We do early mobility assessment and intervention. And for the particular patient that we had, we also engaged with Dementia Services Australia, the Blind Society, Marianne Spencer's team for support because she fell through the gaps for care placement. Ultimately, we did end up transitioning her into a care support facility, but her admission, I think, lasted for like 14 weeks before all of this got sorted out. So in essence, in that 14 weeks, that lady probably had 1 to 2 falls a week. none of those falls related to significant harm. So we have reduced by 50%, but I'd say we're just back to tracking at normal rate. So it looks like a success story, but it's really not. The success was for that particular patient. So this is our physiotherapy department. We currently don't have a physiotherapist on site. We've been unable to recruit. So we are utilising the virtual support services for physio. So these are the key parameters that we've been looking at as to why we do what we do. And this is a population profile of the Warrumbungle Shire, which is where Coonabarabran is, but it also includes the communities of Coolar, Dunedoo and Barradine and a few smaller communities. So as you can see, we sit significantly above the New South Wales state average on every single point. We've got rising elderly population. We have 14.3% of the population is Aboriginal, 2.7 times higher rates of smoking in pregnant mothers. Adult smoking is even higher than that. Obesity among kids and teens is at 58%. Our burden of disease is extreme. So if we wish to make a significant difference for our population, we have to target from birth and we have to start focusing on intergenerational change. So we work off a philosophy that we can't cure someone who has an established chronic disease. However, we can maximise their quality of life. What we're trying to do is affect lifelong change to provide holistic primary care from birth so we can improve health literacy, engagement in preventative strategies and promote healthy lifestyle choices. And that's our aim for the future. This is just one of the 2-bedded wards on the rooms on the ward. So we initially started with what we called a child and family health drop-in clinic, and that recruits young mums and bubs into the antenatal, postnatal and child and family health space with the assistance of the Aboriginal health professional. And we've also got that set up in a yarning circle model. We provide tea and coffee and a socialisation space and a play space for kids while they wait. It's an appointment-free zone. It's well recruited within the community. It's self-sustaining. It's been running for close to 3 years now, and we've got high retention rates now where we're starting to see children from the first round who've now got multiple siblings. We're engaging with fathers and grandparents as well. From that initial family drop-in clinic, we then moved on to a program that we call Kickstart for School. And it's a 7-station assessment process using speech, the lift the lip dental assessment, a hearing assessment, an eyesight assessment, a specific assessment that we coordinated with the virtual OT, Sarah McBurney, for assessment of fine and gross motor skills, which is actually conducted by a registered nurse. Immunisation, age development blue book checks for 4-year-olds, and for any issues that we identify in that space, we do a secondary referral to the service provider that can best meet those needs. For speech in particular, we will also provide the online speech pathology resources for parents while they wait for their speech pathology appointment. So this is the shotgun ward that I was talking about. So as you can see, we've got lots of opportunity to mobilise in a straight line. So also from the Kickstart from the program, we've brought in a program called Active Lorikeets. So we ran the program initially for ourselves in Active Lorikeets. We had 2 people trained up. It's an Australian produced program from a OT and physio based out of Gippsland. It's a play-based program to improve communication, fine and gross motor skills. We've now transitioned that program in partnership over to the local childcare centre. So we have facilitated the education of the childcare workers. We are monitoring that program delivery. We are providing written reports to the parents about the pre and post program results for their children. and any identified issues also generate an early referral for remediation of concerns. What we've now started doing is Jen Staniforth, who is an amazing child and family health nurse, went along and did the exercise coordinators program. She was the only person on the training program that was focusing on anybody that wasn't in an older age bracket. So she felt really odd. But what she's doing is from our early drop-in centre, we identify young mothers who we believe would be ideal for participation. So in the early stages of this, and this exercise program partners with the Murrindali Healthy Eating and Nutrition Program. So between Narelle and Jen, they write an invitation to the mothers to come in and participate in the exercise program and the Murrindali program. Both programs run for 6 weeks. And at the end of the 6 weeks, the program participants swap to the other program. So they do exercise, then Murrindali, or Murrindali and then exercise. So the exercise program we're running is low impact exercise. It's movement appropriate for a postnatal period. It's self-empowering for continuance. It doesn't require any level of equipment. And it's got a high degree of satisfaction at this point in time, and we're hoping to expand that further into the future. I'll talk about Murrindali first. So Murrindali is a Aboriginal specific program. So we're targeting Aboriginal women and children in all of these programs. So we're targeting the new mums. It gives education and demonstration cooking for healthy eating and nutrition education, budget and food safety, food preparation and cooking. We actually get them to share a meal at the end of that. They have socialisation together, and it builds cultural support. It builds social frameworks out in the community for these women to continue on in that space. And Narelle is also trained in quit smoking, so she's targeting young mums in pregnancy who are smoking and getting them linked in with a quit smoking program with their consent. So we have a couple of other programs that we run. So for a number of years now, we've partnered with the Brian Holden Optometry Institute, and they come to Coonabarabran and run optometry clinics every 3 months. So what we've done is we identified from reviewing that program that we were missing children. Children may well have had appointments, but they weren't attending because we were a facility-based program. So we negotiated with the Brian Holden Institute, and we've now mobilised that program into the schools. So we take the optometry assessment into the school. They get a full optometry assessment done. They get early referral to further specialty services if required. If they need corrective measures, they get free glasses. They are put on a cyclical review program back with the program that's monitored, and it has a high degree of success. So we went from having about a 0% attendance to about a 98% attendance for booked children appointments. We've now conducted that mobile clinic in Coonabarabran High School, Coonabarabran Public School, Binnaway Primary School, Barradine Primary School, and we're about to expand to the Catholic school as well this year. The Aboriginal health professional Narelle, she has been trained up in audiometry, and she sourced the equipment to conduct her own audiometry assessments from the ministry. And so she now hosts audiometry assessments on children. She can read and report. She can make the referrals back to the GPs for ongoing assessment, and they've got a programmed review. She has also mobilised this into the schools, and to give you a degree of indication for success, she conducted a clinic yesterday at Coonabarabran Public School. She assessed 17 children during her clinic there yesterday, And of those, 25% of those seen required ongoing referral for corrective measures, whether that be retained fluid in canals, needing further work to be done to ensure that they had appropriate hearing. If we've got good hearing and good eyesight and good lifestyle choices, we can have good education and good opportunity for the future, and all the while building health literacy with young mums that'll be influencing their children.